Hey, as Meredith said, momentum behind immunotherapy in sarcoma is building, and hopefully we are discovering a host of new options that are potential for sarcoma. Because of the advancements in this area, we do have two different speakers that are going to speak on the immune system and immunotherapy because there is just a lot to share, and because both of these speakers are known for their dedication to researching this topic in sarcoma. Our next speaker is Dr. Wilky, and she'll be continuing our discussion on immunotherapy in the field of sarcoma. Dr. Wilky is a sarcoma medical oncologist and clinical trialist at the University of Colorado. Her research interests are in immunotherapy, targeted therapy, precision medicine, and early phase drug development. I personally have had the privilege of hearing Dr. Wilky present on the immune system a few different times, and I know you will be impressed with her knowledge and her talent in the area of immunotherapy and patient education. So Dr. Wilky, the floor is all yours. Thank you.
Thanks so much for that kind introduction, and thanks to the invitation to be talking with all of you today. So I'm going to go ahead and share my screen. Hopefully, see how this goes. Okay, can you guys see my screen?
Yes.
Great.
Yes, we can.
Okay. Awesome. Well, thanks again, and great to be here on Sunday morning. And we had a fabulous introduction to the immune system from Dr. Pollock. So I will sort of pick up where he left off and kind of get into some of these topics in more detail. So I'm using slides that actually I just presented at ESMO, which is the European Society of Medical Oncology. So some of them are a little bit research focused. There's a lot of new data that I'm going to be showing. So again, I'll try to cover as much as I can. But if you guys have questions, again, just put them in the chat and I'm happy to go into anything in more detail. Okay, so Dr. Pollock already went through a great introduction about the immune system, but just the immunotherapy in general is sort of a complicated topic. So I wanted to put out a plug for this website. It's this ucir.org. This is the best source I've ever seen for sort of patient-friendly explanations of immune therapy, the immune system, all these terms that get thrown around. So I'd highly encourage you guys to take a look at it. And they also have these incredible cartoons. So some of these intro slides, again, sort of emphasize the points that Dr. Pollock made. But just as we talk about immunotherapy, and you've heard this already, there are sort of two main types of immune cells that we'll talk a lot about. Number one are the antigen presenting cells. So these are those macrophages, those dendritic cells that Dr. Pollock was talking about. These guys are your policemen, right? They're the military, like he said, that are going around looking for problem cells, for broken cells that may potentially signal threats of cancer or infection. And their job is to go and educate the T cells. So the T cells are the top dogs. They're the ones that are very specific. They're very, very smart, and they know exactly what they're heading out to find because of those T cell receptors that you learned about. And so, as Dr. Pollock mentioned also, why is our brilliant immune system that can cure all kinds of viruses, all kinds of bacteria, fungus, and actually prevents cancer every single day, because we're constantly having breaks in our cells that could potentially develop cancer. It relies on this fact that cancer cells, really, the only way we're going to see them is if they're broken. So there has to be something broken or mutated about the cancer cell, which means that there are these funny shaped proteins or broken proteins that get made and then presented to our immune system. And those are called antigens, okay? So the problem and why immunotherapy doesn't work for everybody is that many cancers, including sarcomas, just don't look broken enough. They don't look foreign to our immune system. Our immune system basically says, this is myself. I'm not supposed to attack myself. This is what's been built into us so that we don't get diseases where our immune system is attacking our own bodies. And so a lot of what we're trying to do with immunotherapy is to make cancer more easily recognized, so that our immune system can see it. Other problems include they can't get into the tumor, or that those immune cells that are specific for the cancer cells are getting shut down by other suppressive factors. And so what are some ways that we can try to fix this? So you heard this also, this is sort of like the three main classes of immunotherapy you can think about. So one way is if your immune system has already figured out that your cancer is bad, but it just can't quite get the job done, that's where these checkpoint protein inhibitors or checkpoint inhibitors that Dr. Pollack was talking about, that's where those come in. So you kind of have to already know, your immune system has to know there's a problem, and then you boost it, right? You make it work better. You take away some of the shut-off signals to try to let the immune system do what it's supposed to do. But if your immune system has no clue that there's a problem, that's where some of these other things come in. So vaccines, viruses, chemo, radiation, these are all ways to try to educate the immune system and try to make cancer cells look more foreign and broken, so that your immune system can hopefully find them. And then the third way is to bypass all of that. And if you know your target, or if you know that you have a population of immune cells that are educated, you just make a whole bunch of them, and then you try to give them back to the patient. And so that's sort of the idea of cell therapy. So we're going to talk a lot about checkpoint proteins. So again, I love these cartoons, but so basically this is sort of a picture of an antigen presenting cell saying to the T cell, hey, wake up, I found something suspicious. And there's basically this complicated set of go signals and stop signals, because as I mentioned, we don't want our immune system just sort of going and killing stuff without being regulated, right? That's how come when you get the flu, you feel like crap for the time that you need to, so that you can neutralize the infection. But at some point, we want to actually turn our immune system off and say, look, the threat's been neutralized. We can go back to normal now. And so that's where the stop signals come in. So basically here, the antigen presenting cells can step on these go buttons and tell the T cell that they need to go attack whatever they found. But then there's also stop signals. So you can see here that you can be signaling, if you're an antigen presenting cell, you can signal through go signals and stop signals. And if the stop signals outweigh the go signals, the T cell's not going to do anything. And sort of your immune response stalls. So the idea here, this is where CTLA-4 checkpoint inhibitors work. So basically CTLA-4 is one of the stop buttons. And if you use a blocker to CTLA-4, in theory, the T cells are only getting go signals. They're not getting those stop signals. And so that actually helps to improve the early steps, that early education piece, and the recruitment of new T cells to go look at stuff and try to join that fight against the cancer. On the other hand, PD-1 and PD-L1, this is typically occurs further along in the process. So if you have T cells that are shown here in blue that know what they're supposed to fight, they know and recognize the cancer cells. Basically, the cancer cells can express PD-L1, which is a stop signal to the T cell by binding against PD-1. Okay. And so when that happens, when that intersection happens, the T cells shut down and then they stop their response. And that allows the cancer cells to continue living. So PD-1 blockade or PD-L1 blockade, there's different forms of this, essentially block that interaction. So you can no longer shut down your T cells by that direct interaction with the cancer cell. And so that's basically where the PD-1 inhibitors or PD-L1 inhibitors work. Now, remember, though, if you don't have any T cells that know what they're doing, this is not going to be helpful. And we think a lot of this is why throwing PD-1 inhibitors alone at sarcomas is not particularly effective for most patients. If you have no idea what you're trying to fight, you can boost it all you want, but the T cells, if they're not there, they're not going to be able to get the job done. Okay, so now we're done with cartoons. You heard about these. This is just another list. There's more and more and more of these coming up, and you'll see trials with all of these different names. But essentially, there's PD-1 blockers, and the three that are approved are shown at the top. I'm going to talk about one called balstilimab a bit today. This is, again, very, very similar to these other PD-1 blockers, but a bunch of smaller companies have their own inhibitors that are essentially all the same thing. PD-L1, there's a couple also that are approved. This is the one that's approved for alveolar soft part sarcoma, and then these are approved in other types of cancer as well. And then CTLA-4, you probably heard about IPI. Tremelimumab is another one that's approved. And then botensilimab I'm going to talk about as well. This is in clinical trials, but an exciting new CTLA-4 blocker. Okay, So I'll just take a step and say, this all sounds amazing, right? I'm going to boost my immune system. It's natural. It's supposed to be fighting my cancer. So all of this is just wonderful. But it's actually not quite as natural as it sounds. And that's because normal cells all through our bodies have don't eat me signals too. They have these checkpoints to prevent the immune system from attacking them. So whenever you use checkpoint inhibitors, in theory, any organ, any part of your body, head to toe, can be mistaken for a threat and your immune system can attack it. And so that's where all of these itises come in. And, most of these are mild. Most of them might just be a little bit of a lab value that's out of range. Most of them we can reverse by suppressing the immune system, which no one wants to hear, but potentially using steroids or blockers to something called TNF. So in Crohn's disease, which is an immune attack on the colon and the small intestine that people can get, we use something called Remicade. You might have heard about that. So this actually works pretty well for treating immune colitis or inflammation of the colon that can happen with these drugs. But the take home is that some of these can be fatal. It's rare, but about 2% of patients that receive PD-1 blockers alone can have a very serious side effect. And we worry about things like inflammation of the lungs, inflammation of the brain, actually, eye inflammation. There's a bunch of different things. And they can be fatal, so which is why we worry about this. The other thing that people don't necessarily understand, and I've had patients where we've literally cured their cancer with immunotherapy. It's incredible, but they're stuck with long-term, lifelong complications like type 1 diabetes. That's because the immune system can attack your pancreas, the cells in your pancreas that make insulin, and you're diabetic for the rest of your life. That's a little hard for some people to wrap their head around. Similarly, I have patients that developed essentially rheumatoid arthritis in their 30s, and yes, their cancer's gone, but now we're using treatments to manage rheumatoid arthritis. So this is why we're so careful and why we don't just throw this stuff out for everybody, and we don't throw it out before we know we need it. So one of the questions earlier was, why shouldn't we be doing this as soon as people are diagnosed? Well, if you've got a shot at being cured by chemotherapy or surgery or treatments that have been better studied, we would certainly want to do that because we don't want to risk the side effects of this stuff, unless we're sure that the cancer is going to be the main problem. Okay, so now we'll shift gears a little bit and talk about clinical trials. So again, a lot of these slides I borrowed from my ESMO talk. So if we talk about checkpoint inhibitors first, basically, these are some of the clinical trials that have been done so far in sarcoma. I don't have time to get into the nitty-gritty of each of these today, but essentially we started from PD-1 alone. That was the SARC-28 study for 4 different types of soft tissue sarcomas and 3 types of bone sarcomas. The Memorial Sloan Kettering group, Dr. Sandra D'Angelo, that many of you may have heard speak, was sort of the first person to look at combined CTLA-4 and PD-1 inhibitors together in sarcomas. Dr. Somaya at MD Anderson ran this trial again with a PD-L1 blocker and a CTLA-4 blocker, and there have been several other studies as well. So what have we actually learned? Like, where are we today? So if you put all of this stuff together, there are certain types of sarcomas that are more likely to respond than others. And so I'm sorry for the abbreviations, and let me know if there's one that you guys don't understand, but this is pleomorphic sarcoma, or UPS, liposarcomas. ASPS is alveolar soft part sarcoma. That is sort of our home run tumor for really one of the highest chances of response. That and cutaneous angiosarcomas. So those are those blood vessel cancers in the skin. Chordomas, and then there's certain types of epithelioid sarcomas and a weird disease called malignant rhabdoid tumors that are missing one of these machineries called SMARCA4. These have all been shown in these various clinical trials to potentially respond. That doesn't mean everybody, but that you've got a shot at somewhere between 20 to 40%, maybe a little bit higher for a couple of these subtypes. But that's what I think of when I say response. Like, this is a real shot at getting something. What's even better is if you happen to have something called high tumor mutation burden. So tumor mutation burden is a measure of how broken your tumor is. How many things are wrong? How many mutations do you have? Because as I mentioned, the more mutations you have, the more broken proteins you make, and the more foreign your tumor can appear to the immune system. So you'll find out what your TMB is often if we do genetic testing, so whole genome sequencing. These are tests like Caris, Foundation Medicine, Tempus. There's a bunch of them, and some of the institutions do sort of their own thing. This is pretty rare in sarcomas. It's only about 1% that have high TMB, but it's worth checking because if you do have it, you have essentially like a 90% plus chance of response to checkpoint inhibitors. So it's always something that I keep in mind, especially for sarcomas that came out of prior radiation exposure. And then it's been reported in some of these other types. This is osteosarcoma, chondrosarcoma, angiosarcomas, and then malignant peripheral nerve sheath tumors. So worth keeping an eye out for that. And then these are the ones that I say kind of fall into that non-responding category. And that doesn't mean you cannot get a response. It just means that you're talking typically somewhere between 0 to 10% chance. And again, when you think about the risks of those side effects, most of the time, if I tell people, I'm like, look, this is a shot in the dark, and I don't use checkpoints by themselves for this, but I would potentially direct people to clinical trials, especially those with combinations with checkpoints, to try to make the tumor more foreign or to try to make immunotherapy work better. So the take home is our two superstars are ASPS and cutaneous angios. And these guys are getting more and more immunotherapy earlier on in the process as a result. Now, what do we do? Are there any drugs out there that might be better for those immune cold tumors or tumors that typically don't respond to PD-1 and CTLA-4 by itself? So this is a new drug. And again, this is data I just presented at the ESMO conference. Botensilimab is a CTLA-4 antibody, but it's been engineered to try to bind better on not necessarily to the CTLA-4 piece, but to the back end of the drug. And this is a little confusing, but what it essentially does is make that communication between antigen-presenting cells or natural killer cells. It helps them talk better to the T cells. And so what this drug has been shown, it's been tested in a phase 1 trial of about 500 patients now across a bunch of different lines of a bunch of different types of cancers. And we've seen benefit in tumors that typically wouldn't respond to immunotherapy, the old school types. So there's something about this drug that's just making it work a little bit better. Even in tumors like colorectal cancer, which almost never respond, we're seeing activity there. So this is data I presented for the sarcoma patients that were treated on this phase 1 trial. There were 52 patients with sarcomas that were heavily pretreated. So most people had had at least 3 prior treatments, meaning chemotherapies, targeted therapies, and other stuff. And this is a waterfall plot. So basically every bar here represents a patient. And if the bar is going down, that's a decrease in the size of the tumor, the diameter of the tumor. If it goes down by 100%, that means the tumors went away. And that's what's shown here. So you can get an idea that there's a decent number of patients that are actually having benefit. And the response rate, which means the tumor shrunk by more than 30%, was about 23% for all of these patients. And I'll show you a little bit more here. What we were really excited about is that if you did respond, like other types of immunotherapy, these people could maintain those responses for a really long time. This is weeks on the trial. So you see the tumors coming down, and then some patients could maintain those responses, meaning the tumor didn't progress, even a couple years out from treatment. So we were super excited because I told you that cutaneous angio, so skin blood vessel cancer, we already kind of know that that's a good tumor to respond to immunotherapy. But anybody who's got angiosarcoma in organs or that started in the breast, what we call primary breast cancer or primary breast angiosarcoma, these are much, much harder to get immunotherapy to work. And so in this waterfall plot, which just shows the 18 angio patients, you can see pretty nice responses in visceral tumors. So that's, again, organ or other sites not in the skin that we would expect. So this is super exciting, 40% response rate in angios. And we also had a couple of responses in D. diff liposarcomas and leiomyosarcomas, especially the soft tissue leiomyosarcoma. So we're pretty excited about, whether or not this is going to hold up in a bigger trial, but their company's planning to move this forward. All right. So that's sort of the checkpoint inhibitors by themselves, but what about combination treatments? So you can combine checkpoint inhibitors with multiple things. So radiation, targeted therapies, which Dr. Pollack talked about, and then chemotherapy. Now it's tricky because sarcomas are rare, and to do a clinical trial that's big enough to where you can actually tell the difference between, are you just having a good response to chemo? Does the immunotherapy actually add anything? That can be hard when everybody gets both treatments, right? So we really need what's called randomized trials, which is where half the patients get chemo alone versus chemo plus immunotherapy, to be able to tell head to head if we're actually doing anything. But the idea with all of this is that we're teaching the immune system, we're making the tumor look more foreign or broken so that the immune system can find it better. So this is a study you guys should all have heard about. If not yet, this is probably the most important thing I'll tell you today. This is the SARC-32 trial that was just presented at the ASCO meeting in June. So this is from Dr. Kirsch, who's in Toronto, but basically this was across multiple centers, and they took patients with newly diagnosed grade 2 or grade 3 UPS, pleomorphic sarcoma, or liposarcomas in the extremities. And what they did was they randomized patients to get either the standard of care, which is radiation, followed by surgery. There's no chemo in this study. And I know that sometimes we use chemotherapy for these tumors, but for this particular study, it was either radiation followed by surgery, or radiation with pembrolizumab, which is the PD-1 inhibitor, followed by surgery, and then continuing pembrolizumab for a year. So this is after the patients have all their tumor removed. There's no metastatic disease here. This is just newly diagnosed. And then they look to see how people did. This was really cool. So what we saw was that for these patients, if you got the immunotherapy, you actually did better. And at 2 years after you had your surgery, 72% of patients were free from cancer versus 54% if they got radiation alone. So that's a good almost 20% improvement in the chance of being disease-free for a new sarcoma. So sort of adding something to our usual paradigm. When they looked at this, they saw that the higher grade tumors tended to do a bit better. There weren't really enough patients to make this definitive, but it makes sense, right? So the higher grade, the more aggressive tumors that you have, potentially the better this helped, or the better this worked. Whereas if you kind of had lower grade, you were probably going to be cured with surgery and radiation anyway, and the immunotherapy didn't add that much. And they saw trends in liposarcomas, although most of the patients on this trial were pleomorphic sarcomas. So super exciting here. The other cool thing that's come out lately, people ask about biomarkers. So like, is there some way that I can predict whether or not I'm going to respond to immunotherapy? In other cancers, you can just test the tumor for PD-L1, which is that don't eat me signal on the cancer cells. And in other cancers, if you have PD-L1 on your tumor, that improves the chances that you're going to respond to immunotherapy. But for reasons we don't understand, that doesn't hold up in sarcoma. You can have PD-L1 and not respond, or you cannot have PD-L1 and still get benefit. So it's more complicated. But this is some data out of the French group, Dr. Italiano and colleagues. And basically, they ran a clinical trial where they put Pembro, which is the PD-1 inhibitor, with an oral chemo called Cytoxan or cyclophosphamide. And they basically treated a bunch of patients with soft tissue sarcomas. And this is a metastatic disease. Now, this was not a great trial. They picked the wrong patients. And so if you just look at that trial when it was first reported, only 2% of patients had shrinkage of more than 30%, which is pretty depressing. But they reported these things called tertiary lymphoid structures. So tertiary lymphoid structures are these clumps of immune cells that can be found within the tumor. This is not as easy as it sounds. You can see these fancy stains for all of these different markers, which go with immune cells. But basically, they did another group of patients where they looked for these little clumps of immune cells, and then they treated only patients that had these, and found that they could bump the number of patients that benefited was up to 30% instead of 2%. So this is not perfect. And again, you can see that there are patients that have TLSs, or these little clumps. Those are shown by the red bars, and they still had a progression of their disease. So this isn't really ready for prime time, but you might hear about this as a biomarker, and there are going to be more clinical trials using this to try to see if this holds up. But at least for right now, it's more of a sign that the immune system, again, is in the building It knows something's going on. It's sort of evidence that your immune system has a clue that the cancer is a bad thing. All right, what about in combination with chemotherapy? This is a super busy slide, but my take home here is we have now done a lot of clinical trials combining different chemo drugs with immunotherapies, with the checkpoint inhibitors. And, basically most of these are all just one arm, like what I was saying, where everybody got everything. So you don't know, because there's small trials, if the chemo necessarily adds anything to the immune therapy. And part of it's fine. Like as long as it's working, we don't necessarily care that much. Like for example, this Immunosarc-2 trial, this is for leiomyosarcoma patients. This is out of the Spanish group, Dr. Martin Brito, and they did doxorubicin and dacarbazine, which is a really good treatment for leiomyosarcoma. That's a good response, typically even with chemo alone. But then they added PD-1 to it, and over half the patients got a tumor shrinkage, and the average time, or the median time for the tumor to behave itself, was over 8 months. So that's pretty good in this setting. But again, without a randomized trial, it's hard to know for sure if that's necessarily making a benefit. But you can basically see here, that these drugs probably do a little bit of something. So I call it this circumstantial evidence. Like we can't prove it, but there's probably some benefit here. And so Dr. Pollock's study, again, great trial, first time that chemo was combined with immuno for, or at least the doxorubicin was combined. And without getting into it today, I'm a believer in that, because doxorubicin is actually a really good drug for making the cancer cells look like they're damaged. It triggers some of the same pathways that the tumor cells would spit out, like the same factors, as if it was infected by a virus. And I know that's crazy, because we think about chemo, especially doxorubicin, of dropping your immune cells to nothing. But again, there's something about those first few days of the exposure where it's a huge danger signal. It's like sending out a giant red flag to your immune system saying, okay, come here, come find me. And so, there's several trials now that have shown this, potential benefit here. And this is Dr. Pollock's trial he was talking about. So again, I'm just sort of showing it again for him. But finally, we're going to have a trial where half the patients, again, this is UPS versus, and sort of related ones. So I think it's pleomorphic sarcoma and myxofibrosarcoma are the two names that would be eligible. And so basically, they're going to randomize to either get doxorubicin with the pembro up front all together, or doxorubicin by itself. And then at the time they progress, they could then, you'll then cross over and be able to get immunotherapy by itself. But this will look at that question: is the combo really better than either one alone? I'll just briefly show this trial too. This was for angiosarcoma patients, where they looked at paclitaxel with and without nivolumab. So again, this is what I'm saying. So if you look at all the patients together, this was also presented at this new ASCO back in June, there was no benefit. So paclitaxel is such a good drug for angiosarcoma that when you added immunotherapy and you looked at everybody, there was no difference. However, if you go in and you look at the types of angiosarcoma, you see some pretty big differences. So if you had scalp and face angiosarcoma, again, the kind that I was telling you is better at being recognized by the immune system, you almost doubled the progression-free survival time. So how long the tumor was well behaved. So it just, again, we have to think about how we do clinical trials, and we have to think about the biology of the patients that are in those trials to make sure we don't miss potential signals of activity. Briefly, checkpoint inhibitors and TKIs. So these are our chemo pills that block blood vessels that eat the tumors. And without getting into it in too much detail, there are about 24 different ways that we think that these pills can positively affect the immune system and the microenvironment. But again, we don't completely understand all that yet. These are, again, studies that have been done of combination treatments, no randomized trial. I'll show you one randomized trial here in a second. Basically, you want to think about these for ASPS for sure. I think that combo is really effective in those tumors, alveolar soft part. Sutent, sunitinib and nivolumab has been studied again by the Spanish group in a really, really big study. And there are patients with dedifferentiated chondrosarcomas and angiosarcomas, again, getting benefits from Sutent plus nivolumab. And there's a bunch of other tumor types included in that one. And then some pretty decent responses with Votrient or pazopanib in soft tissue sarcomas, including desmoplastic small round cell tumor. I know somebody had asked about that. Bone sarcoma, so osteosarcomas, there's several trials combining various TKIs, which are actually pretty good, or at least they can stabilize osteosarcoma when chemotherapy no longer works. They haven't yet proven again if the immuno combo adds anything, but at least, you know, there's again circumstantial evidence that might be helpful. And then a really, really good response at angiosarcoma was seen in the second half of that trial that I just showed you with cabozantinib and nivolumab. This is for patients with angio where paclitaxel did not work, where it stopped working, or they'd already had it. And you can see almost 60% benefit here and long-term benefit. So this is a great combo for angio as well. Real quickly, Dr. Van Tine, who's out at WashU, presented this last year at ASCO. So this was a randomized trial of cabozantinib with or without PD-1 and CTLA-4 together in soft tissue sarcomas. I'm going to fly through this a little bit. But basically what he showed was that with the combination of cabo, which is the chemo pill, plus ipi-nivo, 80% of patients had either stable disease or shrinkage, which is pretty good, compared to 40% for cabozantinib alone. So this was a good sign that the addition was adding something. If patients got cabo alone and then progressed, they could cross over and get the cabo with the immunotherapy. And so those patients, even though cabo was no longer working for them, about half of them went on to still have benefit with the combination. So this is really exciting. The diseases that benefited from this, we were pretty excited about leiomyosarcoma here. Other types as well, but there were, I think there were 2 complete responses also, myxofibro and angio. And then I think that another one came after this. So the final paper is going to come out on this data, but this is a pretty exciting combo. And there's a big phase 3 that's planned with the next generation cabo called zanzalintinib. And so that one will hopefully be coming down the pipe soon. All right, in the interest of time, I'm going to move ahead. You heard a lot about cell therapy. Again, this is just sort of my depiction of the differences between these different things. You can either take blood from a patient and then put in that CAR, like what Dr. Pollock was talking about, or an engineered T cell receptor. There's some differences. For CARs, you have to know the target. You can't just hope for, and that's really, really hard to find. So that's the big limitation why we don't have more CAR T cells for sarcomas, is because there's just very few targets that are only on the tumor, on the surface of the tumor, and not on our healthy cells, because sarcomas are self, right? And they're structural cells. You get a little bit more leeway for your targets with engineered T cells, but as mentioned, these have to be matched to the tumor type or to the person type, the tissue type. That's that HLA type problem that he was talking about. So the idea of TILs, where you don't have to know the target, you don't have to worry about the MHC because it's coming from your own tumor. I think this is really, really cool and really exciting. The problem is they did the first trial, Dr. Molinax, who's out of Moffitt, did a trial of TIL therapy for sarcomas. And so far, it didn't work very well. The reason is that these immune cells that live in sarcomas are pretty crappy immune cells, because if they were good, they would have killed the tumor already, right? So they're exhausted, they're dysfunctional, they don't know how to grow. Like, there's all kinds of problems with these things. And so what Molinax showed, at least, is if you just take out what you have and blow them up, that's not going to be enough. So the idea is you engineer these things to try to make them work better, like Dr. Pollock was saying. And in other types of cancer, they're putting in PD-1. So like your TIL, after they engineer it and mutate it a little bit, will make its own PD-1 antibody to try to improve, to block like the shutoff signal type of thing. They're also engineering some to make something called IL-15, which is a very potent cytokine, a Go cytokine, to try to help with that as well. And then I'll just, briefly put in a plug in a few minutes for one of our engineered TIL protocols that's coming down the pipeline. This is the data for afami-cel, which is the approved synovial sarcoma T cell receptor therapy. 40% response rate in synovial, 25% in myxoid liposarcomas. However, you have to have the antigen, you have to have MAGE-A4 on your tumor, which is about 70% of people, and you have to be that HLA type A2, which is about 30% of people, okay? So it's just hard to find those patients. And honestly, if you respond, you do great. Same sort of thing. But a lot of patients will initially respond, but then progress. So this is not a perfect therapy, and we still have a lot of work to do here. Same thing for Ledi-cel. This is the one, the cell therapy, same type of thing, but it's going against NY-ESO, which is a different marker. Same for synovial sarcoma and myxoid round cell liposarcomas. And you can see, again, most patients had some degree of benefit here, basically about a 40% response rate. So this one's coming up the pipeline. We'll kind of see how things go. But again, really promising. And this one looked a little bit better at 40% for both synovial and myxoid lipo, whereas MAGE-A4 was only about 29 for myxoid lipo. So exciting about this cell therapy too. So keep an eye out for these. This is my colleague, Dr. Davila, who works in the lab with me here in Colorado, and he's come up with this construct, which is essentially a supercharger for TILs. So we are working on a clinical trial that'll hopefully open in a couple of years. We're probably beginning of 2026 is the latest timeline. But basically, this allows for better sensitivity. So when the T cell receptor on your TILs that are taken from your tumor encounter their antigen on the cancer cell, it just lowers the threshold for this to fire and kill. So we're going to try to make them work a little bit better. But this is going to have head and neck cancer, lung cancer, and then soft tissue sarcomas. So I'm super excited to be a part of this trial. All right. So in summary, we've got 4 minutes left. So basically our wish list for immunotherapy, new drugs and combinations. I wish we had better biomarkers to try to figure out which patients are likely to benefit. And so every single clinical trial that we do, if you do an immunotherapy trial, we ask you for biopsies, we ask you for blood samples, and it's so we can try to pool all of those data together and try to understand who it's working for and why, and who it's not working for and why. This is the only way we're going to get past sort of throwing things at these clinical trials and trying to make some sense of the biology and to be able to customize treatment for your tumor and you. Because again, at the end of the day, immunotherapy is treating you, not your cancer. We're treating your immune system to be a better fighter. So it's a kind of a different way to think about how we're treating cancer anyway. We need more randomized trials, and we've got a couple that are coming. We want to work on the lab better. There's not very many models of sarcomas in mice that have immune systems to study, and most mice that we use human tumors for don't have an immune system, so it makes it a little bit tricky, but there are ways around this. So we've been working really hard in the lab to try to understand this. And the last thing I'll just say to all of you, so it's so tempting to hear these results and be like, oh my gosh, I want immunotherapy. We really want to try to avoid using these things off label and try to go to clinical trials when you can. And the reason is, number one, we'll never learn if we don't put people on trials. But also, as I mentioned, the side effects can be severe. And if you're a patient with a 1% chance of response, your chances of side effects become a real problem. And so we don't want to put you guys at risk. We want to at least be able to do this in a way where we learn something and where you can be safely monitored, and that you don't wind up having sort of lifelong issues, without having your cancer benefit as well. All right, that's it. And I think I have like 2 minutes for questions. So thank you.
Thank you so much, Dr. Wilky. There were a lot of questions and a lot of discussion in the chat. If you have a few minutes, would love to see if you could expand on some of those directly in the chat, just since we want to stay on time. I'll just pull out a couple that I think were more general questions.
Okay.
One was about immunotherapy used to prevent recurrence in some of those disease types that have shown a response to immunotherapy.
Right.
Are those only being used in the setting of active disease, or are there opportunities or trials that are looking at using that as a way to prevent recurrence?
Yeah, so at this point, there's very, very little data to prevent it from coming back. The only trial that I think I would feel comfortable doing that in is what I showed you with SARC-32. So those are those higher grade UPS or liposarcomas in the extremity that are getting surgery, right, for standard of care. In that setting, especially for patients that are not chemo candidates, because a lot of people, we will counsel patients with high risk tumors using that Sarculator app where we predict the risk of your sarcoma coming back somewhere down the road. That's how we recommend chemo or not. But I have a lot of patients in their 70s or, maybe that have other medical problems that are not candidates. So to be able to see something that actually can improve the risk of or improve the risk of recurrence and have a better side effect profile, for me, is a great thing. But that's the only trial that I know of where there's been proof of, you know, some sort of improvement in response. Like everything else is really in the setting of metastatic disease. So I don't use it to prevent recurrence. I use it when I have something to follow, because again, the risk of side effects when you don't know whether you even need the treatment it's a problem.
You also talked about SARC 032 and that trial, and you mentioned it was limited to the extremities. Is there a reason that that was limited to the extremities, or a reason to believe that those that have UPS in the trunk or abdomen might have a different response?
Yeah, it's a great question. There have been other trials. There's one out of MD Anderson where they did the same sort of thing, and I think they had patients with retroperitoneal abdominal tumors. That was a tiny number of patients, so the data was not quite as strong in that paper. So we really need another study to look at that in more detail. I mean, if I had someone where they absolutely weren't a chemo candidate and there was a shot at getting to a surgery and we were going to do radiation anyway, I think I'd think about it, but it hasn't directly been studied in that trial.
Okay. Well, thank you. With that, I think let's move to the poll. And maybe if you have a couple minutes, just quickly to scan the chat and see if there's anything you feel comfortable answering, that would be great.
Will do.
One